All right, as promised, we are going to start now. This is Sarah DeSilvi, Director of Terminology for the Gravity Project. I have the honor of leading you in today's last end-to-end review of our digital literacy and digital access work. I will not be on camera today, which is unusual for me because I come to you from my parents' home. I'm on vacation this week, but coming to you still to carry this work to fruition. So thank you for letting me come to you on my vacation time from the coast of Maine. Next slide, please. As always, we are so grateful for you to join this meeting and so grateful for the work that's come from this collective over the course of the last months as we've worked together on digital access and digital literacy build. We do start with muted attendees. We are a really core group now, so we do try to facilitate conversations as we're able. The call is always recorded so that we can go back and review things if needed. You can find this on the Confluence. And as per usual, everyone's encouraged to join through the chat. If you send your chats to everybody, I will integrate them into the conversation as best I can. And again, if for any reason I'm missing anything, please hold me accountable. And again, sorry for any notifications coming in as I'm on my home computer. Next slide, please. This is the common antitrust practices slide. We all have a responsibility to comply fully with federal and state antitrust laws, as we do in all meetings. And we just want to make sure that we follow according to those in our collective over the next hour. We probably will have a short call, even though I always do myself when I say that, because the end-to-end review is in such a good spot right now. Next slide, please. Just always, again, a nod to our 2023 sponsors. If we could have done this work without all of them. A specific nod and thanks to our friends at KP, Kaiser Permanente, who really leaned in to specifically support this digital access and digital literacy work. They were instrumental in carrying these domains to fruition, and we wouldn't have been able to do this without them specifically. But all of our members are really critical in all of the work we do across our 3 work streams. And if you have any interest in becoming a 2023 member, you can always find information on sponsoring on the Confluence. We have a pretty exciting new model that really centers members in driving the strategic agenda and the labor and priorities of Gravity Project. And I hope you research that and look into it, because I think it'll feel very much like these meetings that we have here, where your voice is centered and it enables us to continue to do the work we do addressing health equity. Next slide, please. It's a little bit of the Sarah show today, only because we do have so many of our friends on vacation. It is August. Our time frame was jogged a little bit. Usually we do have the summer off to do build and education, but because of a delayed start, we are building and reviewing into August. So some of our colleagues are on vacation. So you'll hear a lot of me over the course of the next hour as we give updates on the end-to-end review. We'll be going through very small updates and then closing out with the requirements we have ahead of us to head into the vote in our next meeting. Next slide, please. Next slide. A note, as I mentioned, we are operating a little bit on a tiny team here on the Gravity terminology team. So I'm going to be doing hyperlinks while my colleague Sarah Bahal does slides and allows people to enter the meeting. So please patience with me as I try to navigate into the hyperlinks to get them into the chat. Huge kudos to my colleagues and friends in the technical work stream. Corey Smith is here today. He's our technical director for the successful publication of STU 2.1. There's a lot of work from our colleagues and friends at MITRE in this as well. We encourage everybody to review it. It's really quite lovely, the work that happened over the course of the last months and year. So please go and look at it. We just want to make sure everyone can participate in that work and reflect on it. Again, just congratulations all around. Again, STU 2.1 out in the ecosystem for your review, and the link is in the chat. We want to just applaud again our friends in the technical work stream, again, Corey and the team at MITRE on a successful July CMS HL7 Connectathon. We did do testing of the fire implementation guide, and we had that new use case you've seen on the roadmap, and we'll talk about it briefly, which is a proof of concept for social needs for social needs for supplemental benefits, and that was tested as well. Really exciting Connectathon, and we look forward to future Connectathons that you'll be seeing on the bottom. So we might be looking forward directly into January, but the next Connectathon is, of course, in the September working group meeting in Phoenix, and there's another January Connectathon. All the Connectathons and how to get involved with them are on the Confluence. So if anybody has interest in testing at the Connectathon, please let us know. We would love to have anyone on the team anyone in the meeting bring a team to the Connectathon to test terminologies and exchange. So please just reach out to any of us on the Gravity team, and we'd love to get you connected with people you might need to test with at the Connectathons upcoming. But again, mostly just want to give huge kudos to the team on the technical work stream and for the publication of 2.1. And also to the successful HL7 CMS Connectathon that just happened in July. Next slide, please. Next slide. This is the roadmap. There are some pretty exciting things coming up that we're working on getting prioritized and funded for upcoming work. More on those very shortly, but you can see here we are closing out our digital access and digital literacy build. We will then in terminology go into build dissemination and evaluation in September and through the rest of the fall. And we are going to be trying to maintain a cadence here just to keep you all engaged so we don't completely sunset this collective, just please know that. And the technical work stream, again, the STU 2.1 was published, so excellent work there. The use case for the supplemental benefits was tested at the Connectathon, so great job there. Again, looking forward into the September and then January Connectathon, that's that line in orange. And then everything is really plugging along on the pilot work stream as well with our 4 public health and health equity pilots. And as promised, that last line there is the social care co-design work, which is leaning into social care voices, specifically over a series of co-design sessions. We've talked about that in past meetings. That starts on August 10th. So even if the build kind of sunsets with digital access and digital literacy, we're going to be heading into this social care co-design push in on August 10th. So very exciting work happening over the course of the next months. Next slide, please. Any questions on announcements or anything or any of the updates from a Connectathon or looking forward to future Connectathons? It looks like not. Okay, next slide. This is the section where usually my colleague Hamali leads it. She's a really critical member of our terminology team, but again, she is on vacation, well-earned vacation this week. And so very honored to center a dear colleague and friend and critical force on both the technical and terminology work streams, Monique Van Berkom, to give updates on value sets briefly on the next slide. Next slide. Just as a grounding, if you remember last meeting, we mentioned the work that was done to make question and answer level value sets. This is different than that. It just goes to show all of the work that happens behind the scenes. And usually, again, this work is happening not when we're doing public domain work, but because of cadence, we're doing it all at the same time. It's been a very busy summer. Monique?
Yes, so these are the updates to the value sets for those who follow the IG, to the 5 profiles in the IG, the goals profile, the condition profile, which is where the diagnoses go, and the service request and procedure profile, which is where the interventions go. And what Himali's showing here is basically for a significant number of value sets that are already in VSAC, new codes were added. So there was a total, I think she says at the bottom, of about 550 new codes, and those are distributed as she's showing here in the code count column. She wanted to make a special note that the lines in the light yellow are ICD codes that have not yet been added, but will be added shortly as they come out in VSAC. The other codes were added over the last month and are already in. So this is just for anyone who wants to sort of see where there's new content and how much new content there is.
Thank you, Monique.
Yeah.
We do want to just note that this is a little bit off our normal cadence. We do aim to have our value set work completed by June, but there is a lot of value set work this year because of the new work in those question and answer level value sets and the ongoing terminology value set upgrades. So there was a lot to do. Eugenia is asking if we'll share the new SNOMED CT codes. There is a function within VSAC that allows you to see changes between value sets and the last time you access them. So if you want to see specifically the SNOMED CT elements that we've added, that is probably the easiest way to note them. They all are part of past domain build. Notably, if you look, there's a lot of terminology that was published in collaboration with the Veterans Administration as part of our veteran status build, specifically in interventions. So the easiest way to see the specific terms is doing that change log between previously accessed value sets and the new ones, and you can see the actual elements that changed. Otherwise, you can see them reflected very easily in our past masters based on the different domains. That might be the easiest way. Eugenia, will that work? We also can probably provide you whatever, all of the different documentations also in our, share drive and our internal change control processes. So if there's specific terms you want to know about, we can absolutely lean into those as well. But the noting the change between two different iterations of the value sets is the best way. And again, just a nod, reiterating what Monique said, ICD-10-CM is a little later than usual getting published into VSAC, so we weren't able to update those ICD-10-CM value sets, but they will be updated shortly in early August, in like the next week or so, as soon as they come out. All right, next slide. Thank you, Monique.
Sure.
And next slide. Okay, here we are in end-to-end review. And again, this is where this meeting may not be very lengthy because of the amount of collective work we've done so far. And this is really kudos to you. So it's two basically distinct domains over the course of the last months. And we've all been working so actively together as a collective. There were very few comments that were submitted early enough to get them in front of the subject matter experts. So there were a few comments. We have to have them in time to process them and get them to the subject matter expert meetings on Tuesday. This week, after that time, we've gotten two more. Again, the deadline for all comments in end-to-end review is Saturday. So far, there's two existing comments that are out in the ecosystem that we have not processed yet and adjudicated yet. But what you're seeing here are the comments that have been processed and adjudicated from the collective. And I just want to thank you all for perfectly following instructions and sending your emails with notes and comments and justifications. Again, just so grateful for the investment of this community. And so we're going to be reviewing those very, very small edits to the two different master lists and builds over the course of the next minutes, and then closing with just kind of reflection on the work to come, and making sure that all of you have just a note. Again, if you have not submitted comments, the deadline is the 5th. Okay, next slide. And you can see it here. So the deadline for comments is the 5th, because we need to process and adjudicate every comment from formal end-to-end review in time for you all to see the final master lists for consensus voting, which is again very formal. We follow HL7 consensus voting processes. So there's a collective vote occurring on the 17th of August that reflects all the work that we've done. So submit your comments by the 5th. We'll adjudicate them with subject matter experts at our next meeting. Thank you, Sarah Bahal. Yeah, and then we'll get a final masters in front of you with a sufficient time to review them before the vote live on the 17th. Again, very exciting work that we've done over the course of the last months. So thank you so much. Next slide, please. All right. Again, the purpose of end-to-end review is to review what we've done together as a collective and ask ourselves whether there's missing concepts that we need to add. Are there incorrect concepts that need to be changed? Are there unnecessary comments that should be removed? All comments and edits have to be offered in written form via email with suggestions and evidence for alternate approaches sent to gravityproject@hl7.org. And then we have to adjudicate them with our subject matter experts. And just a note on process, just so you all can hear, once we finish this master list, we then of course go into build with the different terminologies. ICD-10 CM Coordination and Maintenance Committee, SNOMED CT, SNOMED International, and LOINC and Regenstrief and LOINC. Most specifically, I would say our colleagues at SNOMED really rely upon us having citations and references. So you will hear us sometimes not being able to change a definition if it's for a program that has a citation and reference that we cannot change. You will also sometimes hear us not being able to change instruments because we are not the owner or author of the instrument. And so therefore we cannot change it because, again, Regenstrief requires us to have a citation and a reference for that instrument in order to build it into LOINC. And I just say that as a level set. So that is a bound that we have, which is to be evidence-based and cited, with internationally or nationally recognized definitions when able, and to not edit instruments that we haven't authored. So just know that those are some of the bounds that we work within. So even if we acknowledge the wisdom of a comment, sometimes we can't change it just because we're bound by the processes that we have to follow next. And you'll see us return with those kinds of comments as we adjudicate whatever end-to-end review comments you have. I just want to make sure that everyone hears that as we go forward. Does that make sense? It seems like it must make sense. So if anyone has any questions, happy to offer that back. But again, it's because if you were to see our SNOMED CT submissions, there is a citation for everything. Like everything has a reference and everything has a citation in order to make sure, really in the grounds of semantic consistency, that we're not making things up. Samantha, hello. Do you have a
Hi there. I just wanted to ask one question about that, and forgive me since I know that I joined this particular team's work later than the first meeting. So you may have covered this, but as someone who recently shared comments, I'm curious, is there any iterative quality to that adjudication process? In other words, is there ever a time when the subject matter experts say, you've shared something important, potentially important here, but we're not satisfied with the level of citation in your evidence section? Is there anything else you can send, or is that kind of back and forth not feasible?
That back and forth is entirely feasible. And I hope you see that in some of the, even in this current vote, you're going to see comments at the end terms at the end that aren't directly related to digital access and digital literacy,
Great.
but that we are having to revisit. The evidence has evolved, and therefore our definition has to evolve. And so we had to bring it back to the collective with better definitions and citations and resolve it. Right.
Terrific.
Terrific.
Yeah. All right. Yeah. Thank you so much.
Absolutely. We exist in practice within an evolving system, an ecosystem. And as long as there's sufficient evidence to justify the change, then we support that, right? So 100%. And that's why a few slides ago, the evaluation, everything we're doing here is new. Now it's 4 years new, right? Because we've been doing it for 4 years, but we always have to test our hypotheses against implementation. So feeding back what we're learning, both from implementation and feeding back what we're learning as evidence evolves, is part of the expected process.
Thank you.
Great. Any other questions? Hi, Lucy. All right. Okay, it seems like we're all grounded again. I just wanted to make sure everyone understood that there are these bounds that we have. We can't just be, and you'll see actually what the things that are in our power to change, things that we're collectively crafting, such as the definitions of our diagnoses. Those are more flexible because, believe it or not, we're in the position of having to do that as well. Luckily for our subject matter experts, they help guide that work. All right, next slide. Just want to again make sure everyone's aware. It seems like everyone's really has this down now, but The domain masters for digital literacy and digital access are always the source of truth, reflecting the most up-to-date changes in definitions and terms. So if you are adjudicating something or making comments, it's important to reference those. There are very small edits. Oh, hello, Raphael. We can make sure, if Raphael, if you write an email to gravityproject@8till7.org, we'll make sure that we get you all oriented. Welcome back. It's always good to see former friends. We're returning friends, I should say. So we just want to make sure that everyone's aware that tomorrow on Friday at 5 p.m. EST is when we publish the masters that will reflect the changes you see here today. So if you are wanting to make comments, you might want to look at that. However, that is so close to the deadline for enter and review comments. Just know it's all good, and we'll just make sure that we integrate whatever you have to say into the current master. But the masters are available on the Confluence. The most up-to-date version is always available on the Friday after the call, unless there's an extensive amount of work to do, as there was a couple weeks ago. We had to delay it until Monday. But just make sure everyone's aware of that part of the process. Okay, next slide, please. And next slide. All right. Again, and I will do that. I have the honor of doing this today, and I have the honor of doing this again in 2 weeks. I just want to make sure to give sincere, deep thanks to these brilliant 5 subject matter experts who have guided us in our work. We are so grateful for Walter Soares, Adriana Nava, Adriana Aguilera, Gumi Camajola, and Jorge Rodriguez, who have helped ground our conversation weekly every Tuesday from 4 to 5 Eastern Standard Time, making sure that we stay on target within best practice for both the conceptual definitions and practice of addressing digital access and digital literacy. We, again, could not have done it without them. So very grateful. I think Walter's on the call. I cannot see if anyone else is on the call, but again, just deep thanks to these 5 who've helped spearhead this work. They are priceless. And as anyone who's been a SME before, you become a SME for life because of the way that quality measures and regulation are referencing gravity standards. We often have questions, Samantha, just to reference your comment after the fact, like new instruments or new areas of inquiry that Gravity is asked to weigh in on, and we reach out to these subject matter experts with queries regularly just to make sure we stay on target, including, new gold standard instruments. So just very, very grateful for these 5 experts. We would not have been able to do without them. So thank you so much. Next slide. All right, next slide. There are, I know, thank you, Walter. There are so few changes, and this meeting might be, again, very, very short, but there's so few changes. I just want to highlight the changes. I'm going to take a brief pause and say no change, no change, no change on each slide, and then pause when there's a change, right? Just to respect the fact you've all seen these slides multiple times now. So there's no change here. Next slide. Change here, right? So we had a really wonderful comment from our longtime colleague, Janice.
So sorry, Sarah, if you go back just one quick, maybe typo. It should be inadequate digital access due to lack of in the first column. There's a missing TO after due.
Oh, we didn't. It's funny because we corrected it on the previous slide, but not this one. Thank you, Walter.
All right.
Yes, thank you in the ICD-10-CM column. Thank you. Noted. Thank you. Thank you. And luckily, Sarah Bahal is right there. So if there's, and Monique, I have the best friends to make sure that doesn't happen ever again. Thank you, Walter. So again, here we are on the where changes were made. This is due to a comment that was made in our last call that was then formally submitted for end-to-end review. Just wanting to note that within the inadequate digital access and inadequate digital literacy affecting healthcare element, that there was a desire to represent the enrollment area of healthcare because of how digital access, digital literacy are crucial for signing up for insurance on the exchange. So prior to, you can see the prior definition did not have enrollment. We all agreed that enrollment and access to healthcare options on the electronic exchange was a significant addition. And so and this is again a definition that we crafted because there was not a definition prior. So we have added enrollment. Again, thank you to Janice for her engagement with the Gravity Project forever and for her service on our strategic committee. She's one of the leaders of our committees.
Thank you. I just want to say I sent it to the wrong person. I just thank you, but I sent it to Amy. Anyway, I'm trying to thank everybody. Yeah, it is important. I brought this up in another meeting today and they're like, yeah, that is true. We don't think people think about access usually in different, in different ways. So enrollment's really important.
Yeah, and I just want to note that already reflected you tapped right into some of the comments Boomi, one of our subject matter experts, was processing during our SME huddles as well. So it was very timely and we appreciate it. And give Amy all the thanks anyway. Amy's been such an amazing member of the group. We appreciate Amy's efforts as well. You can thank Amy too.
Yay.
Yes. All right. And there's not very, so this is the only change here. And then we go, the next slide is no change.
Sarah,
Yes.
Sarah, before you go to the next slide, enrollment opens up a whole new realm, at least in my mind, one of the most important aspects of which is identity verification. And I'm wondering if that should be included. Should I put that in an email? I did not have a chance to review the access. I only did the literacy, but enrollment is not possible without identity verification. And there are going to be times when that's remote and that the actuaries, is that what? No, the notaries of America are now deep into this issue about remote identity verification within healthcare. So that immediately comes up in my little mind. So I'm wondering enrollment, comma, identity verification, treatment, diagnosis, and so forth.
Lucy, thank you. I hate to ask you to do this because we just got your amazing and thorough comments, but for the sake of process, would you mind just sending an email? Perfect. I know. I just want to make sure.
Okay.
Thank you.
Of course.
Yes, thank you so much. It's a very good point. And again, this is where we might be able to say if it's a necessary component, it might be included in it and not needing to be called out, but we'll really have to think carefully about that, about whether it needs to be called out specifically. And we are so grateful for your continued advocacy as always, Lucy. Yeah, so Corey, that's what I was just saying. So if it's a required component, it might be included, but we really need to make sure we think about that carefully. And again, thank you as always. Such a good patient voice, dear Lucy. Any other thoughts? All right. There's not much. We keep on going. Next slide. No changes here. Next slide. No changes here. Next slide. Again, these comments, this does not reflect the comments we got after the fact. So there's a couple comments we haven't processed yet because we didn't get them in time to review and process in time for the Tuesday meeting with subject matter experts, but they'll be reviewed at the next meeting on Tuesday. So if you're not seeing your comment reflected here, that is why. No changes here. Next slide. All right. Oops, I think, yes, okay, we're good. Then no changes here. Next slide. So sorry. No changes here. We do have a couple changes here. Our thorough commenters noted that we had a couple programs and professions that did not have definitions. Thank you so much. So they are not here, but they are cited definitions that so for lawyer, we have the current definition is Bar of American Bar Association. We thought that was a good one. And then for Care Navigator, we referenced the existing Navigator definition that was in SNOMED CT because it was very applicable for this purpose. And again, allows us to leverage synonymous terms. So if you look at the new master, you'll see that there are definitions now across digital access and digital literacy for both lawyer and Care Navigator with citations and references, again, as we look forward into build with SNOMED.
One quick comment on that as well. In the recently released, we're right now under review, CMS 2024 physician fee schedule. They are incorporating payment to what they call principal illness navigation services.
Mhm.
So this will be a specific category under their billing system, the CMS billing for physician services. I don't know if that has any effect on kind of like, should we consider adding that term, principal illness navigation services or navigator? But you know,
Yes.
we just a thought, not that we need to solve it right now, but
Walter, that's just, I think, where we're going to have to, and again, Monique and Hamali, who's not here, and Asha, who's not here, and Sarah and I have been thinking deeply about these kinds of things because there's lots of synonymous terms in the navigator space. And there really is a need to kind of lean in to what differentiate, like digital navigator is a specific type of navigator with a specific purpose, right? And we come into problems with building into SNOMED CT whenever we cannot submit a profession that is not defined within the National Uniform Claim Commission, within that taxonomy. So I think what we're going to probably have to do for a little bit is just hold space for all of the synonyms as the ecosystem figures itself out, and allow for, mappings. Basically, you can see this in our definitions where we have and includes but not limited to. When we have like a patient navigator term and we have the different types of navigation that apply. Does that make sense, Walter?
yes, absolutely it does. And this one in the proposed rule is more about navigation of services,
Yes.
specifically in cancer treatment and treatment of other serious illnesses. So it's more, rather than digital navigator, it's really more like a navigator of the process for getting care.
Yeah, that's why it's more akin to the Care Navigator term.
Yes, exactly.
Also has a synonym of patient navigator, right? And so
Yes.
again, so this is where, but again, we're kind of bound to what is in the National Uniform Claim Commission, and we'll hope that they're advocates to help drive consensus, and we'll be part of that, right? To make sure
Yeah.
that we have a clear idea of what a navigator is, and so that we can eventually make sure that that's we have that all set. So Walter, like 100% agree.
Yeah, thank you. No, that's it.
Yeah, for right now, the Care Navigator and Patient Navigator are essentially synonyms within our work right now, whereas specific subtypes of navigation that have specific areas of focus, like Digital Navigator, would be a subset of them. But this is the, again, very grateful for the request to get the definitions for lawyer and Care Navigator into the system. Again, you can see them across digital access and digital literacy.
Sarah, I would
Sorry.
second the idea of paying a lot of attention to care navigators and how different systems and payers may define them, because the stress on equity from the highest level in the Biden administration has produced the realization that navigators are an essential element to promote equity. And so everybody is now trying to conceptualize what a navigator is, and payers are going to start paying them, as Walter has just suggested. So one sort of, not in our job description, but to the extent that Gravity is aware of all these possible definitions, eventually everybody's going to need to land on a term, and this is what Gravity is so good at.
Yeah,
So,
and at least documenting the complexity is definitely what Gravity does a really good
yes,
job at.
absolutely.
Yeah,
Great.
and Amy, I want to reassure you, if I misspoke, I apologize. Patient navigator and care navigator are reasonably synonyms, but digital navigator is very different and is defined differently. I don't want to worry you
Yeah,
about.
okay, thank
Yeah,
you.
I saw your
Is-
comment. I'm like, please, I'm so
was-
sorry.
Was there discussion about the difference between a digital navigator and a digital health navigator? I'm sorry that I haven't been able to be on all the calls.
Well, Amy, you are brilliant, and there was not. So if there, again, this end-to-end review is about missing terms. At least I don't remember someone submitting it as a specific term. I do. So if you could help us by submitting it as something you see to be missing with a definition and citation, that'd be really helpful, because we do, in my mind, that might be helpful across these domains and our health literacy domains from last year, right?
If somebody can work with me offline to know
Yeah.
where to submit it, because
Happy to.
and what to submit, because I don't really have the whole navigation of this
We-
whole operation down
have
pat.
been such an amazing member of the community. We are more than happy to send you a ping after this meeting to help
That would be
facilitate
great.
your wisdom.
Thank you.
Yeah, no problem. Any other questions or comments? Thank you, Monique, for dropping in the patient navigator definition. Jonathan, I think Sarah Bahal is actually on the call. She can testify to that. We're about to update them with the new masters, so they might be in process. Sarah, did you see Jonathan's question regarding the spreadsheets? I'm gonna.
Yeah, I did. So currently, there are masters on the Confluence. They were updated like 2 weeks ago, since that was our last community meeting, and they'll be updated again tomorrow.
And so for some reason, thank you so much, Sarah, the master behind the masters. And so Jonathan, if you're having trouble accessing them, please let us know. I just want to note, this was actually, Jonathan, thank you for noting, you were one of the commenters who noted that we had missing definitions. So thank you so much for your end-to-end review. And Amy, we have copied your information and we'll get you engaged. Fantastic. Okay, next slide, please. And then there's no changes to instruments. And I'm just going to pause for a second, because what you're going to see as we go through digital access instruments is no change. And then when we get to digital literacy, it's really just repeating the same end-to-end review elements we had before. So next slide, please. No changes here. Next slide. Next slide. No changes here. And then here is where you see again that element of enrollment changing because of our colleague Janice's comment. Thank you. And again, just noting, of course, Lucy's question on identity verification would apply here as well. So we note the mirroring of these terms across the two different domains. And there have been, just of reference, there have been other comments that we have to adjudicate in reference to these specific terms. So we'll make sure we knit all of that together when we see this SMEs again on Tuesday. Just make sure, again, you get your comments in before Saturday so that we have time to review them and get them to the SMEs on Tuesday. And just thank you so much. So again, this is the only edit to the definitions for digital literacy. Again, the addition of that enrollment element. Next slide, please. Next slide. Next slide. No change. Next slide. No change. Same change. Where we had our new definitions for a lawyer and care navigator. And just noting again that we work with Amy on the differentiation between digital navigator and digital health navigator that would apply to both digital access and digital literacy if accepted. And thank you so much for that. And then next slide. There were no changes to digital literacy instruments. Next slide. Next slide. All right, so pause. Those are the formal comments that we had in N10 review on the specific definitions and instruments and terms for digital access and digital literacy. You will see there were only 2 major changes, and that was the addition of enrollment and clarification of definitions. Thank you. You can see my notifications are still coming through. And now we're going to pivot into some of the patterns we applied on assistive technologies. We do have some comments to process on these as well. Next slide, please. These are the assistive, there's a little bit of a sweet delay there for me. These are the considerations of assistive technologies and addressing language barriers and translation needs that we applied from health literacy to digital access and digital literacy. The changes, Jonathan, will be reflected in the masters in the next version published tomorrow at 5. Right, so we just need to, they actually are all ready to go because there were so few changes, but we'll see them again tomorrow at 5. Again, that's not time enough to disseminate them because comments are due by Saturday. But you can see the changes reflected that we see here tomorrow at 5. Same Confluence, same link, same page. Yes, yes. All right, and then, so these are the, again, the terms that we collectively crafted just to consider. I do want to just note that there was a lot of conversation that we had regarding a need to dive specifically into language barriers and translation needs. I want to also note that if you look into some of the upcoming focuses in USCDI V5, right? If we look ahead, the Office of the National Coordinator is leaning into some of these documentation of translation needs and some of their focus for priorities for the next year. As someone who has the honor of sitting on HITAC and participating and last year co-chairing the Interoperability Standards Work Group, I'm going to be happy to bring some of the wisdom we have here into that space. But just want to note that we did decide that as we had long thought, that translation needs and language barriers really require due diligence to lean in specifically, and we look forward to addressing that in a future domain work. But this is what we felt comfortable building with based on our patterns for health literacy. Any questions from this? Again, no changes from last time. All right, and just thank you for all of the comments we had to support the need to look into translation needs and language barriers and cultural needs specifically. Next slide. Next slide. And this is again, Samantha, what we were talking about earlier. So these are things that we are evolving based on implementation or about evolution of evidence. Next slide. Next, and you can see there's a little circle. There's a feedback loop from evaluation back into the work we do. Next slide. One was a revision of our definition for coordination because it was really not complete. So we collectively worked on an updated definition of coordination. Again, the reference for this was the work of the of AHRQ, our original definition. There was no term for coordination prior to our work. So we're very grateful for referencing that. And that was part of our early build in 2019 that we just needed to update with a better citation, a more robust patient-centered definition. And this will again will be part of the vote on August 17th. Next slide, please. Nothing is formal, finalized within Gravity until you all vote on it as members and our collective. So even if we have agreed upon this for months, it's not final until the vote on the 17th. We also agreed to update the definition of referral because it was far too clinic-centric within our aims of social care. So we did so and updated it with a better definition, which is really just a definition that we got from Merriam-Webster from the good old dictionary to make sure it was applicable for multiple social care purposes, including community-based organization to community-based organization outside of the clinical ecosystem. Next slide.
Sarah,
Hi, yes.
is the concept of support implicit in the word help? When I think of help, I think I ask a question and I get an answer. When I think support, I think of groups or ongoing or somebody calling every week or
Interesting. So you think that the word support has more on,
just to me, if support is implicit in the notion of help in the minds of other people on this call, especially caregivers, that's fine.
yes, it seems, yeah, I think we should lean into that a little bit. And then Teresa, I think it means both in this purpose, both location and organization. As person means both a specific role and a profession. It's broad, intentionally broad. But if there's any concerns with this, again, Lucy, I'm listening to you. I'm just making sure that, hi, Samantha. You're welcome to come off mute and just and speak. But I think
I just wanted to add to Lucy's question with the recognition that these definitions are super challenging. I would just wanted to echo what I see Kate putting in the chat, whether information is the same as resource. I think in many contexts in the healthcare, the social care world, the word resources often is an umbrella term that captures information, but it also captures concrete supports like food, right? Because one scenario in the nutrition context is information about applying for SNAP, but the other is here's a food pantry where you can actually get fresh veggies or fill in the blank. So I do think I appreciate all of the questions about whether the three words here are capturing everything that we mean. And I'm not sure that I have a great suggestion other than that I echo whether perhaps the word resources should be in there.
I'm going to echo and amplify that because I agree with both of them, but I would take it at one additional step forward, and that is there's a difference between giving someone the phone number of the food pantry and getting the person from the food pantry on the phone and actually doing the person's application for SNAP benefits with them in real time. And those are huge differences in effectiveness and in resources, but I wouldn't have any idea how to capture that.
Amy, one of the questions I have is whether that is something that's contained in a different action, right? So if I think about my clinical practice, right, I refer with a touch of a button, right? And I coordinate by ongoing action, right? My care coordinators, my community health workers, my own calling of, the clinician who I'm passing the case off to or to the WIC office. I just want to note that maybe the things that we're seeking are actually represented in different activities than simply referral. And I'm not giving any answers here. But in practice, a referral can be as simple as generating a referral to, where the labor of connecting is often done in the labor of coordination. Does that make sense?
Yes, it absolutely does, but it totally underscores the difference between pushing a button and then being reliant on the person at the other end to contact the patient versus actually getting them on the phone in real
100%.
time.
Which is partly why coordination and navigation are being leaned into as supported services that need to be compensated.
Yeah.
Because actually where the value is, it's not in my touch of a button. It is in the coordination and navigation to the thing to ensure successful connection and services delivered and needs met, right?
Yeah.
And Tom, I just keep on using the word navigation. So if you look under the roles of navigators, coordination is definitely one of the key facets that that is concluded there, but I know I'm sitting here thinking Tom is.
Can
Tom is-
I,
Yeah,
can I ask one question?
you can ask as many questions as you need to.
When I was thinking of resource, I was thinking of the 360X and
Yeah.
referrals to, say, a social hub.
Yeah.
And that's neither really a place or a person.
Mhm.
So with the act of directing someone or directing their care to a resource that would then propagate out to the information, the help, or the action.
That's helpful. Okay, so I'm just going to synthesize what I hear us saying. Number one, even within the specificity of what a referral has mentioned before, we might be able to have better words such as examining place, examining information versus resources, and examining support versus help, right? Like really trying to make sure that it's representing the breadth of what happens in the activity of referral, right? I also hear us talking about the value of that we know to be in the ecosystem in social care and medical social care integration, and even clinical care, based on the new proposed rule, of the important thing that happens next, which is coordination navigation. Tom is very accurately raising whether the act of navigation is successfully included in our little taxonomy of activities, and I think we have to investigate that. But is that a good summary of what we've said so far, just to make sure? Jonathan has his hand up. Jonathan? Hi.
Yeah, I don't have a question as much as a comment,
Okay.
just to kind of reiterate some things that I've said before. I think that being overly prescriptive to start could be provincial in the long term. I think having an umbrella that has catch-alls and then being able to parse it out as you get more feedback from the demographics that you're dealing with will kind of direct you down like how deep the rabbit holes need to be and how many rabbit holes you need to have. Does that make sense?
Yeah, and I'll add to that, Sarah, that I think we landed here. We had been deeper in the weeds and came up to not be over prescriptive. And also this definition came directly from, I think, the Cambridge dictionary. So it was from a source rather than us just sort of creating it. But yeah, we've been on sort of both sides of this fence. So it's good to hear all the feedback, but it's been a bit of a journey with this one.
Well, and to that point, right? If that's a Cambridge dictionary definition, the ability to give that broad umbrella and a framework, and then be able to drill down on it when we get stakeholder engagement and feedback, I think makes more sense than creating more obstacles and barriers to overcome and then trying to decouple it later.
Yeah, and I think that's how we landed here, Jonathan. But yes, agree. I tend to agree, but it's there may be differences. I see there's other hands. So.
Lucy and then Samantha. Bye, Brian.
The term in the first line, assistance, assisting, why do we need both of those words? We don't have coordination, coordinating, education, educating. Could we just have assistance here?
It's because there are synonyms that are often used interchangeably in SNOMED, and we didn't want to box ourselves out with only having one. So sometimes it's assisting and sometimes it's assistance, and we just wanted to honor legacy terms, but we certainly don't. We do new build with just assistance, but we just were honoring legacy assistings.
Well, I guess I don't understand that. I agree with Jonathan that aiming to simplify in the first round is going to invite exactly the conversation that we're having now together in this meeting, namely that we all have different interpretations and nuances for all of these concepts. So if we want to start simple and then elaborate as needed based on experience and feedback aside from this meeting, I'm not understanding the difference between assistance and assisting. And
So
if we're going to do that, we need to have these gerunds for everything else, coordination, coordinating. I mean, it just doesn't make sense to me.
Yeah, we can definitely revisit. So this is actually not new. That's been the way it is since 2019. The only thing changing
Well,
on
we were less wise in 2019.
we were less wise in 2019. Right. So the only things changing right now are the and I can absolutely testify. I was definitely less wise in 2019. But happy to look into that again. Really, we're and I think what Monique said is very much in reference to what we said before, is that we can't change, we can document complexity and future desires, but we have limitations of changing things when we have a reference. We have to kind of stay with that. But it's important to document needs and see how it evolves over time. And then, but I do want to hold space for the navigation thing because that's a little bit different. And then I'm just going to put that in the thinking cap. And I thank Tom for the reference. Samantha, one more comment before we move on.
All right, thanks, but I'm going to do a double header. So
Okay. Okay.
thank you all so much. This is so important. And I guess I had two thoughts I just wanted to lift up. One, I don't think we're the first to be grappling with what this continuum of tasks and activities is in social care. I mean, obviously it's very new, but I just wonder if, for example, some railroad tracks from the framework of SBIRT, SBIRT, from the world of substance use treatment might be useful. Not, and I recognize there's a lot of limitations to how to, import those, but I guess I just want to put out there that could be another continuum for us to look to as we think about whether we're using new words or words that might already have some I don't know, some infrastructure around them. Second, I just wanted to offer to our group that going back to someone's comment, and forgive me, I can't remember who it was at this point, about the difference between, giving someone a phone number and doing something more substantive. While the words I'm about to use don't belong on this definition list, I feel like what we're grappling with is healthcare's longstanding practical, deployment of, on the one hand, cool handoffs, the phone number alone, versus so-called warm handoffs. And again, we wouldn't use either of those terms here, not just because I think they're imprecise, but they're also dehumanizing, I would argue. But I guess I don't think we have, like, in this moment all the time we need to think through that. But I really, really appreciate the effort to distinguish in this terminology between what would functionally be a cool handoff and what would be a more meaningful warm handoff. I'll stop there.
No, I that's 100% appropriate. And I just want to honor that what you're saying, Samantha, is a lot. When we think about these terms, we're also thinking about supporting social care partners in labor, right? So it's like from a social justice framework, right? If it's not just supporting the patient, it's also supporting the people who are doing the work, right? So just noting that part of what we're teasing out is how the terminologies we're developing can be tested to document labor from a social justice framework. And I also want to just note that just from a historical perspective, although you cannot see the citations, there are citations from SAMHSA. There's citations from a lot of the evolution in 2019, even though we were less wise, Lucy, it actually involved us changing definitions that were in like SNOMED CT, for example, to make them more aligned, like the word, like counseling, right? To make them more aligned with best practice definitions from things like SAMHSA or things like, education, literature, and pedagogy. So 100%, we definitely need to reference alternate way, like SBIRT, right? I think about SBIRT all the time because I work in primary care, but thank you for that. I think it's very important and very apropos as we do our work. Oh, thank you, Jonathan. All right. Okay, next slide. We're almost there, I think. Any other comments here? There's a lot to consider, some boundaries because of definitions and some documenting complexity. This is another example of where the system evolved to consider adjustment I think about this all the time now in my own practice as a family practice clinician when I'm adjusting a plan of care in order to meet patient barriers and patient boundaries and support them as a critical activity. And we had not had this in our list of things. You saw it was not on the table on the previous slides because it didn't exist in 2019 as a defined term. And this is really due to the work of the National Academies and their report on integrating social care into delivery of healthcare. So this is a new term you'll see on that table of activities very, very shortly, with just one term, which is the adjustment of clinical plan to accommodate social risk. Again, not as good as addressing the structural barrier, but better than leaving a patient with a care plan that does not meet their needs. And next slide, please. All right, next slide. Friends, it is 5:03. And here I did it. I said we were going to have a short meeting, and we did not have a short meeting because you all are so thoughtful, and we all appreciate that so much. I have tried as best I can to put hyperlinks in there. Jonathan, in my hyperlink check, the masters are still there, the ones that are not current and will be current as of tomorrow at 5. You all really have one primary objective. If you've not commented on the masters yet, please do so by Saturday. And then our job as a terminology team is to take those comments, synthesize them, present them to subject matter experts, and ready a final master for vote on August 17th. I want you all to feel very proud of the work that you all have done over the course of the last months. It really is pretty impressive. And I know at this point, it's amazing, just like Ray was saying from NAC last time, how I will be using these terms to tell the stories of the patients I see in rural Vermont on a regular basis once they're in the ecosystem. Again, the objective is to comment on things that are missing, things that are incorrect, and things that are unnecessary and should be removed, and submit them by August 5th. I have humbly put the 2 hyperlinks to the 2 Confluence pages where you can find these masters. Next slide, please. Here are our meetings. Terminology, again, we'll be back here on August 17th. Look for on August 17th a plan for how to keep you all engaged over the fall as we ship out a direct public consensus into build, but we really want to make sure we keep you all engaged. The technical work stream meets bi-weekly from 1 to 2 Eastern Standard Time. Please join us in implementation on the pilot work stream. There is no August pilot call because we are instead gathering in person. Part of the objectives of the pilot work stream was to do in-person gathering. We'll be gathering together at the Civitas annual conference. So if anyone wants to come and join us at our partners in implementation, Civitas Networks for Health will be at National Harbor, Maryland on the 21st, 22nd, 23rd. But in September, you can reconvene again to join the public health equity pilots on the last Thursday of every month. The meetings you can find on the HL7 calendar. And again, if anyone wants to become a sponsor and help drive our work for 2024 and beyond, please join us in this work. We're very, very grateful for our sponsors. And just another nod, I know I said in the beginning, but a note that the digital access and digital literacy work would not have been possible without our friends at Kaiser Permanente. So thank you, KP, for knowing these terms need to be built and for supporting this work. Thank you, friends. And now I will go back to my vacation. Even though this was so lovely, of course I couldn't miss it. I will see you all in 2 weeks. Please submit those comments, and we look forward to seeing you again soon.
Thank you, Sarah.
Thank you, Sarah. Thanks, everyone.
Sarah, and everybody.
Thank you.
Have a great vacation.